This is Cate Swannell for the MJA. Our special guest today is Professor Alicia Jenkins, Professor of Diabetes and Vascular Medicine at the University of Sydney and also an endocrinologist at St Vincent's Hospital in Melbourne. Welcome.
Thank you very much, Kate. I'm very pleased to be here today.
Excellent. You're also the 2014 winner of the MJA MDA National NOSL Global Health Prize. Congratulations on that. The task this year was to write an open letter to Ban Ki-moon, the United Nations Secretary General, about a health issue you felt needed more attention. And being an endocrinologist, you went with diabetes. Can you tell us a bit about why and how and what you said?
I'm very pleased to be the winner of this competition because, one, in order to disseminate the word to my fellow healthcare professionals about the global burden that diabetes already is, and also because it gets me into a global health leadership course where hopefully I will upskill and be better prepared to do something about the global epidemic of diabetes, extending some of my current endeavours. Why I chose to write about diabetes, apart from being an endocrinologist who has a particular interest in the prediction and prevention of diabetes and its complications, is that in both the developed and the developing countries, diabetes is already a major health problem. And as the healthcare professionals and students listening to this will be aware, diabetes, even without any complications, can have a significant negative impact on a person's health and life, be it type 1 diabetes, type 2 diabetes or gestational diabetes, which of course can then impact that child right through their adult life. But then if people develop complications like the blindness, the kidney failure, the amputations, the accelerated cardiovascular disease, it can be quite a burden both for the individual and for the healthcare system. Yeah. And this is the case even in affluent countries such as Australia, where we're fortunate to live and work. But the challenges and the burden in less affluent countries is phenomenal. I mean, currently, as of last year, there were 382 million people around the world with diabetes, and that's predicted to grow by another 200 million over the next 25 years. Wow. And a lot of that is not changes in our genetics, it's related to changes in lifestyle. And most of these people, particularly over the next 25 years who develop diabetes, over 70% of them will be in the less affluent developing countries. And much of that, particularly type 2 diabetes, is preventable. And the other area close to my heart, as my particular interest is type 1 diabetes, is that the prognosis for people with type 1 diabetes in developing countries is dramatically different than it is in Australia.
Is that a lack of access to insulin?
In many cases, yes. Often the doctors in these countries, not always, but in many cases, these doctors are as knowledgeable and interested in diabetes care and specifically type 1 diabetes. But particularly if the person or the family with type 1 diabetes is impoverished, they can't afford insulin. So through the work that I do with two international diabetes charities, Insulin for Life and the International Diabetes Federation Life for a Child, I know that many children and young adults and other adults will die within days or weeks or months or just a few years of developing type 1 diabetes. And a lot of it is simply that the healthcare system in their country, unlike our system in Australia, does not provide subsidised medical care or subsidised medication.
Yes.
And insulin alone is very expensive. Plus then when you add in blood glucose monitoring, that's usually unaffordable, but even insulin is unaffordable. A vial of insulin often represents 50% of a family's income in many of the developing countries.
That seems amazing to me. I mean, I don't know how many years it's been since insulin was discovered, but to have it still be unavailable in that way
Yeah.
is amazing.
Insulin was first used, sort of by Banting and Best in 1922.
Wow.
And here we are over 90 years later, and as Edwin Gale, a UK endocrinologist who also champions the cause of diabetes around the world, commented that the commonest cause of death of a child with diabetes in the world today is simply lack of access to insulin. And it's not that the insulin's not available, can't be purchased in those countries.
Yeah.
It's that the government or the family can't afford to buy it.
Yeah.
And this is where the two charities that I work with provide to the hospitals and clinics that insulin and related testing supplies.
Tell us a little more about those two charities.
I'm very proud that both of those charities have been founded and led from Australia. So first of all, Insulin for Life. That was founded by two wonderful Australians, Ron Raab and Bruce Wainwright, both of whom are men who have had type 1 diabetes for over 50, and in Bruce's case over 60 years. And they became aware of the difference between their prognosis and healthcare access and that of people with type 1 diabetes in less affluent countries. So over 20 years ago they established Insulin for Life, and it's still going. I joined them after I came back from 7 years research in the US in about 2000, and I'm on their board and their medical advisors, and we certainly welcome more healthcare professional support. But what Insulin for Life does is we collect in-date unopened insulin from within Australia and 9 other countries that we've encouraged to also establish a collection and distribution centre. And we send it to hospitals and clinics in probably about over 30 disadvantaged countries around the world. And the doctors and the nurses there provide it at no cost to their impoverished.
Is that a large amount of unused insulin lying around?
We're probably only getting a fraction of it.
Yeah.
In that we're usually sending out about 100,000 mils of insulin each year. Our network from all around the world is probably sending around over 250,000 mils of insulin, and there's a lot more that we're not getting.
Yeah.
And where we get it from are, for example, leftovers after diabetes camps, or if a woman's had insulin requiring gestational diabetes, and just those few extra vials left over are enough when you add them all together. Because to save the life of a person with type 1 diabetes in a developing country, you're often talking a dozen vials of insulin for a year. Well, we do have a website, insulinforlife.org, and either patients who no longer need that insulin because they no longer have gestational diabetes, or they've changed from multiple daily injections to an insulin pump, or they've changed to a new type of insulin that has come out, can send that directly to our distribution centre in Ballarat. There are also many endocrinology units where the doctors or the diabetes educators, they bring it back to us and we will ship it to Insulin for Life.
Terrific.
So we'd welcome any sort of further inquiries as to, or ideas as to how people can help. The other charity is the IDF Life for a Child program, and that was established probably about 12 years ago by Professor Martin Sellink and Dr. Graham Ogle, who are paediatric endocrinologists in Sydney. And Graham Ogle now works full-time in managing this program, and I'm fortunate to be on the board of the Life for a Child program, and we have a partnership between Insulin for Life and Life for a Child. The Life for a Child program does a range of things to support children and young adults up to the age of 26 years in currently 45 different countries, and there's 15,000 people around the world who are supported by that program. And the Life for a Child program, in some cases, will have Insulin for Life send in supplies.
Right.
In many cases, it provides the funding to the hospitals and clinics so that the hospital and clinic can purchase the insulin and the syringes and 2 blood glucose testing strips a day for the patients who can't afford it. They also cover the costs of the annual complication screening along the lines of what people in Australia would have an eye check, a kidney check. So that has also been growing sort of steadily over the last decade, but you know, that is still only a fraction of the number of children and young people around the world who need this sort of assistance.
How much trouble are we in with diabetes in Australia? Wide-ranging question, I know, but...
A lot. I think, I mean, on an individual level, we have 1 million Australians who have diabetes. 125,000 of them have type 1 diabetes. Most of the others have type 2 diabetes. Gestational diabetes is also becoming much more common, mainly because of the increase in obesity in young women, which is, you know, a major risk factor.
Yeah.
So about 7.5% of Australians have diabetes, but many young adults, and even some children, are at high risk of developing type 2 diabetes, which used to be seen as a condition of old age, but often it's now starting in middle age and sometimes even in childhood.
In your essay, you mentioned your mother. I mean, you've been around diabetes all your life. Can you tell us a little bit about what she went through?
My mother was diagnosed with type 1 diabetes at age 18. She lived in, this was in 1939,
right.
And she lived in a farming community in the Goulburn Valley. It took 2 weeks for the doctors who recognised that she had type 1 diabetes to find an endocrinologist in Melbourne to arrange her admission and stabilisation. And pleasingly, probably partly due to good genetics, but also very much due to her personal diligence, the support that she had predominantly from her general practitioners, and later on in her life from some endocrinologists and from optometrists and ophthalmologists and diabetes educators. She lived with her type 1 diabetes in her own home until 91 years of age.
Wow.
So when she was first diagnosed, the average person with type 1 diabetes, even in an affluent country, lived to 10 years. So she and her parents were told that, you know, she probably wouldn't live very long. It might be that she shouldn't go on to university, which unfortunately she wasn't able to do. And in fact, at that stage, I had many other patients of similar sort of age and diabetes duration where they weren't allowed to go to university, or they had to leave the nursing course that they were doing. They were often advised not to get married, not to have children. Fortunately, my mother and father decided that having children was something they very much wanted to do. But now, people with type 1 diabetes, you know, marry, have children, they're elite athletes, they travel the world, they're our colleagues, they're teachers, they're politicians, they're engineers. It has changed enormously.
Do you think people don't take diabetes seriously in terms of what it can do to you in the long term?
I think there are some people, and even some healthcare professionals, who don't appreciate the damage that diabetes can do and how much we can do to prevent it. The prognosis for people with either type 1 or type 2 diabetes has improved enormously. In fact, now, take the example of my mother, who certainly beat the odds through her own diligence and the healthcare she was able to access, and probably some genetic elements. But now, if people with type 1 diabetes don't get the renal complications, then there's no reduction in their life expectancy.
Right.
But unfortunately, if people with diabetes do get particularly the kidney damage, then that often goes with vision loss and accelerated atherosclerosis, and they may lose decades off their life expectancy. And, well, it's true that people with either type 1 or type 2 diabetes who don't have any of the complications, it's still a daily challenge for them. I don't want to underestimate that one nanosecond. But it's still a daily challenge, but they can still go around their daily lives, you know, with all of their work and their recreation and their family and their community responsibilities. That's very hard to do if you can't see. You're not allowed to drive, or you need to be having dialysis 3 times a week, or you've had your leg amputated. And unfortunately, diabetes, as healthcare professionals listening to this will know, diabetes is one of the commonest causes in Australia of vision loss in adults. It's one of the commonest causes of people being on renal dialysis or renal transplantation, and a sizable proportion, often a third to a half of patients in coronary care units or having bypass surgery are there because they had diabetes or pre-diabetes. So it's particularly burdensome if you get the complications.
Tell us a little bit about the research you're doing at the moment.
Okay. I've got several arms to the research that I'm doing, and as I mentioned earlier, the burden of diabetes gets particularly high, as does the cost to society and the individual and the healthcare system when complications develop. So a major theme of my research has always been to understand why some people with type 1 or type 2 diabetes do very well, like my mother, whereas others, even in Australia, in their 20s have lost vision, their kidneys are failing. And so we understand now that it's not just glucose control, it's more about, it also involves changes in blood pressure and lipids and inflammation and insulin resistance. And we're delving down into sort of into the cellular level in terms of looking at genetic markers and telomere length and epigenetics, the interface between the environment and the genetics, to see if we can better predict early on for a person who has got diabetes whether their trajectory is likely to be one where they're not likely to get complications, or one where unfortunately they're very high risk, so that we can target preventative treatments and perhaps rates of assessing complications to those high-risk people. And that, of course, also is very reassuring for an individual to know that it's not incredibly high risk, because I certainly see patients where they think, oh, complications are inevitable, particularly family members or people they know have had them, and therefore they feel as if, well, I may as well just be lax about everything, it's going to happen to me anyway, because it does take a lot of effort for individuals to look after their diabetes well, to control all the risk factors, to avoid complications, or to reverse the complications, which is possible in some cases if it's found early, or to at least slow them down. And I'm also involved in clinical trials in both type 1 and type 2 diabetes of money-resistant medications such as fenofibrate and metformin in type 1 diabetes, to see if that can further reduce the rates of diabetes complications. We do. So the artificial pancreas, or the bionic pancreas as it's sometimes called, is an insulin pump linked to a continuous glucose sensor, then with sort of a little computer algorithm which may sit on a smartphone or a tablet. And our team with David O'Neill here at St Vincent's Hospital, and Peter Coleman and his team at the Royal Melbourne, and Tim Jones, who's a paediatric endocrinologist in Western Australia in Perth, we're very fortunate to be studying the artificial pancreas at least overnight, where the pump can take control and increase or decrease the insulin accordingly. So that's not yet available for clinical use, but the results in Australia and from overseas are looking pretty promising, and there are some groups around the world who are currently trialling this with people out and about, going around their usual daily activities, where you have the additional challenge of food and exercise.
Yeah.
So that is progressing very, very well.
You gave Ban Ki-moon a lot to think about, really.
I hope he and the others will put diabetes on their agenda.
Thanks for your time.
Thank you.
Perfect.